Good evening, everyone. Thank you so much for tuning in to this month's Headache School. My name is Dr. Laura Silla. I'm a fourth-year neurology resident at the University of Utah. Um, I was asked to give this presentation today regarding the trigeminal autonomic cephalalgias, or TACs, with a little bit of a twist. So let's go ahead and get into it. So today, we're going to talk about the trigeminal autonomic cephalalgias. And for trigeminal autonomic cephalalgias, these are different than the typical headaches that people think about, because immediately people will think about migraines, right? Well, these are a little bit different. And I would like to outline the ones that are the most studied, and that includes hemicrania continua, paroxysmal hemicrania, cluster headache, suncta, and also, I just wanted to note that for each one of these, I'm going to be discussing diagnosis criteria, treatment, as well as the pathophysiology. As the name implies, hemicrania continua is a continuous unilateral headache. So you can kind of look at the name hemicrania, half of the head. This is usually behind the eye. It's in the forehead and the temporal region. For diagnosis of this, you usually will need one cranial autonomic symptom. And cranial autonomic symptoms are things such as tearing of the eye, conjunctival injection, which essentially means redness of the white part of your eye. If you have, like a runny, stuffy nose, changes such as that. So in addition to one cranial autonomic symptom, this needs to be occurring for at least 3 months straight. In terms of epidemiology, this is male predominance. Male to female ratio is about 2 to 1. This usually presents in the fourth to sixth decade of life. So most patients will be in their 40s to 60s when this presents. The treatment for this is quite simple, actually. It's indomethacin. So people typically will have a profound response to indomethacin. People will have such a good response to this medication that it's actually a medication that we will use to help secure the diagnosis. Sometimes the diagnosis is not always certain. And if people have a very, very good response to indomethacin, then that would lead us to think this is potentially hemicrania continua. However, it is important to note that one must trial indomethacin for a good amount of time to just kind of make sure that individuals having a good response to it. So this is usually around 1 to 2 weeks of indomethacin at 750 milligrams 3 times a day at the very least. But now, getting into the fun part of it is I thought it'd be really interesting to see what AI thinks these headaches look like. Basically, I got on Chat GPT, their Dolly software, and I told them a variety of things regarding these trigeminal autonomic cephalalgias. So let's see what ChatGPT thinks about hemicrania continua. Okay, so as we can see right here, this will help you remember hemicrania continua. If you look at this man's face, it's half his head, hemicrania. If you look at his eye, he's having some sort of maybe swelling of his eyelid, some reddening of the eye, perhaps. And you'll also notice half of his head is indomethacin. This should help you remember that indomethacin is the main form of treatment for this. So remember, half the head, hemicrania continua, and indomethacin. Something that I also thought was really interesting in the background is you'll notice there's a calendar. And that should help you remember that this is continuous. It's going on for much, much, much longer than many of the other TACs. So it's continuous, it's half of the head, and it's treated with indomethacin. I will point out that using AI is actually quite interesting because oftentimes there's a lot of misspellings and it's kind of interesting. You're like, I wonder why that happened. So you can see indomethacin is misspelled, but I think the general overall picture can help you remember it quite well. So essentially, this is what hemicrania continua looks like to AI, which I thought was fascinating. Here's another one. So this can help you remember, again, hemicrania continua, half the head, severe pain. You can see there's something going on with his eyes, maybe one, one of his irises is larger than the other. So typically in reality, you can see one pupil larger than the other. You wouldn't see a difference in the size of iris. But you can see half of his head again is with this indomethacin. So moving on to the next one, paroxysmal hemicrania. First off, like hemicrania continua, you can kind of parse out what it means by the name. So paroxysm, right? So something that occurs suddenly, it's not continuous, and then hemicrania, half the head. So how to diagnose this? These are paroxysms or kind of, bursts of pain, and there are at least 20 of them, and they last 20, 30 minutes at a time, more than 5 times a day. So this is the criteria for this. In addition, there has to be a cranial autonomic symptom. So again, if you think about it, these are the things like the redness of the eye, the tearing, the stuffy nose, the runny nose, those kind of things. Um, there are different kinds. So there's the chronic form. There's also the episodic form. So these usually last 7 days to 1 year. And to be episodic, there needs to be a remission for at least 3 months. In the chronic form, however, remission lasts less than 3 months. So that's kind of unfortunate. In terms of epidemiology, this is usually a 1-to-1 male to female ratio presenting in the third to fourth decade of life, meaning that patients are typically 30 to 40 years old or so. Interestingly, the treatment is also indomethacin, and the initial dose is 150 milligrams daily, and this then is increased to 225 milligrams daily. We can also do it intravenously, 100 to 200 milligrams intravenously. So, one way you can help remember the difference between paroxysmal hemicrania and hemicrania continua, of course, is that just look at the name, paroxysmal hemicrania and hemicrania continua. One you can expect to be continuous, right? Okay, so let's see what AI has to say about this. Okay, so this one's great. I love this one. So if you go ahead and look at this woman, you can see that she has sort of this thunderbolt of lightning hitting her head. This can make you kind of remember that it's sudden. It's a paroxysm of pain, right? She has this striking her head. She is very alarmed. She's very caught off guard. So this should help you differentiate from the hemicrania continua, where it's a continuous phenomenon. Something else that I thought was kind of cool is in the background, you can see it's a clock. And it's not just any clock, it's actually a stopwatch. So stopwatches are used to show, short amounts of time. This can help you remember the paroxysmal or the kind of briefer episodes of this headache. Again, you can see she's dumping out some pills. They look like the indomethacin pills that we saw on the first slide. So, okay. So just a note on indomethacin. So I know I keep talking a little bit about indomethacin and how great it is for paroxysmal hemicrania or hemicrania continua. However, indomethacin is not a possibility in all patients. So some patients, they're not able to take indomethacin. So those with GI or kidney dysfunction. So people who have maybe had, GI bleeds, and sometimes this medication can be hard on the kidneys. So for those with chronic kidney disease. And interestingly, in these populations, an alternative is actually melatonin at very high doses. So this is around 9 to 20 milligrams nightly. For those of you who use melatonin for sleep, as you know, this is probably ranging into 3 to 5 milligrams nightly. So this is actually quite high compared to the dose that one would use for sleep. Interestingly, this has been demonstrated in several case reports. And the initial thought is, wow, why does this work? And it's thought that this works because indomethacin and melatonin actually will share a similar chemical structure. There are other things you could try as well. If melatonin is causing individuals to be too drowsy, for example, you could consider medications such as acetazolamide, which is also known as Diamox, if any of you have heard of that, topiramate or Topamax. Some other ones you can consider are gabapentin, lamotrigine, cyclooxygenase 2 inhibitors, nerve blocks, and Botox. Something else one can consider for a more natural route is Boswellia serrata, or also known as frankincense. This has been shown to actually reduce the frequency and severity of TACs in 4 patients. So Not a large study at all, only 4 patients, but I thought it'd be interesting to mention. Okay, I couldn't help myself. I had to look into this, and I told ChatGPT, I said, show me melatonin and indomethacin together and one triumphing over the other. And so you can see here, there's a large melatonin and an indomethacin falling down at the bottom. And you can see that there's this man standing on the indomethacin and he looks very victorious. So just this should help you remember that melatonin and indomethacin, they can both be used, but sometimes melatonin comes out as more victorious in the situation. All right, so now let's talk about cluster headache. So I think most people have probably heard about cluster headache if you have learned a bit about headaches. This is probably the most well-studied of the trigeminal autonomic cephalalgias. And this is typically a headache that is side-locked, meaning it's on one side of the head. It's usually associated with the eye, so people will have severe, excruciating orbital, so around the eye, supraorbital above the eye, or temporal pain lasting for 15 to 180 minutes at a time. These attacks will also occur about 8 times per day. So there are different forms of this. There's episodic. So when I say episodic, what this means is that these attacks that are occurring 8 times a day, they occur in clusters. So maybe during certain times of the year, someone will have many of these attacks lasting weeks to months, but then there will be a remission, and these individuals will not have any of these attacks, possibly for months to years. So to be the episodic variety, remission has to be at least 3 months at a time. Unfortunately, there is also a chronic variant of this, and remission is less than 3 months. And pain is occurring for a year without remission, which is obviously very terrible. In terms of epidemiology, this is 3 times more likely in men, so much, much more common in men. It's usually presenting from 20 to 49 years old. The male to female ratio is about 7.2 to 1 for the episodic variant and 11 to 1 for the chronic variant. So when you think of cluster headache, you should really think, okay, so this is like an excruciating side lock pain, typically focused in the eye or the temporal region, and much more common in men. Um, there is some interesting discussion regarding this because this has always been regarded to be a trigeminal autonomic cephalalgia that is more common in men. However, some studies have suggested that perhaps women are often underdiagnosed in this field, and they're frequently misdiagnosed as migraine. And so these ratios of 7.2 to 1 or 11 to 1 may actually not be accurate. Something else that I thought was very interesting about cluster headache is there might actually be a link between chronic tobacco use and secondary exposure to tobacco smoke. For whatever reason, this has been shown to have a very close association with cluster headache. Cluster headache also has rhythmicity, and attacks will occur in the spring and the fall. And I'm not quite sure why, but it's something very interesting to think about. The treatment for this is 100% oxygen and subcutaneous or intranasal triptan. So these are the medications like sumatriptan, or you might know it as Imitrex. For preventative medication, um, this is really only used when people have active cluster headaches at around 4 weeks or longer. For this, people will use verapamil, which is a calcium channel blocker. This will be about 200 to 480 milligrams daily. Um, this is also considered pretty safe in pregnancy and lactation. So this is really important for, my patients who are maybe considering getting pregnant, or they are pregnant, but they have these really terrible headaches. And so verapamil is always what I usually go to first. There are some other options, as you can see written on the screen right here. There has also been a few studies to show that non-invasive vagal nerve stimulation has also been shown to help. Interestingly, as I mentioned earlier, cluster headache is probably the best studied and the best understood of all the trigeminal autonomic cephalalgias. And so because of that, there are many more studies dedicated to the treatment of cluster headache, and you start seeing some more interesting choices for treatment. So there are therapies under investigation, such as Botox, ketamine, also some psychedelics, such as mushrooms and LSD. So, but now let's get on to what you all have probably been waiting for, is seeing what does AI think of cluster headache? Let's see. Okay, so what do we have here? Let's see. We have a man sitting there, so that should help you remember that this is much more common in men, right? He's sitting there and he has a big red eye. This should help you remember that it's typically located in the eye region. You can also see redness of the eye. So we have a autonomic symptom that we're witnessing right here. You can see that the pupil is extremely large, right? Again, that's another autonomic symptom that we might expect. Interestingly, you can see he has some sort of oxygen mask, perhaps, contraption on his face. This should help you remember that the acute treatment for this is oxygen. I'm not really sure what he's holding in his hands. Looks like a vial of something. It can help you perhaps remember something like ketamine. You can also see that there are a bunch of little floating mushrooms in the background. This should help you, and it's also kind of a whimsical representation, right? You can see floating mushrooms, they're different colors, they're kind of flying off into space. This should help you remember that many of the treatments for cluster headache, because this is the most studied, are really expanded in different areas, including mushrooms, psychedelics, and ketamine. Um, Lastly, I'd like to point out that you can also see it looks kind of like a sunny day outside in this photo, or this picture rather. And this should help you remember that there is a rhythmicity to these kinds of headaches, and they're occurring in certain seasons. So you can see there's also a flower on the edge here. So it helps you remember that it can occur in the spring. All right, now let's get into another form of headache. So there is the short-lasting unilateral neuralgiform headache attacks. So these are called SUNCT or SUNA. And so essentially, SUNCT is going to have conjunctival injection, so the short-lasting unilateral neuralgia form with conjunctival injection, and then the other one does not have conjunctival injection. So what is the criteria for this? So the criteria, this is short-lasting severe pain, usually in the V1 to V2 distribution. And for those of you who perhaps needed a refresher, so the trigeminal nerve, which is the cranial nerve number 5, is highly implicated in headache as well as sensation of the face. So if you just recall for a moment, so we have something called the trigeminal nerve. You can think about it coming out from basically right here. It extends on your face, right? So you have V1 up here, V2, and V3. So essentially, you have nerves traveling along the course of your face. So the short-lasting severe pain is occurring in V1 and V2 distribution. So you can remember that. For SUNCT, so this is the conjunctival injection and tearing, as I mentioned. SUNA can have conjunctival injection or tearing, but it doesn't have both. So the way to remember this is if there is conjunctival injection, if you recall, that means kind of the redness of the white parts of the eye, and then tearing, you know you're dealing with SUNCT. But if you have one or the other, you're dealing with SUNA. And so essentially, for criteria of this, there needs to be around 20 attacks, moderate to severe, and this will typically involve the head, the orbital, the supraorbital, the temporal, or cranial nerve 5 in general pain, and this lasts around 1 to 600 seconds. This is a very interesting headache because this is often brought on by very benign activities. So if you're just living your daily life, someone might have kind of an attack of this SUNCT or SUNA variety. And this can be things simple like brushing teeth, washing hair, putting hair behind an ear. This is really important because this often will lead to the misdiagnosis of SUNCT or SUNA. There is another entity in the field of neurology that we think about a lot called trigeminal neuralgia. Something that we're classically taught in medical school is that benign activities such as, breeze, hitting the face, slight touch of the face, moving fingers right here can cause extreme pain. And so the question is, As clinicians, how does one differentiate between the two? And so this is an important question because the treatment is, somewhat different. So in the conjunctival injection is less profound in trigeminal neuralgia. Um, and it's one of those things that if you see it, you'll know. So it's thought that the conjunctival injection or the redness of the eye is very profound in Sankt or Suna. In trigeminal neuralgia, there's usually a refractory period. In addition, trigeminal neuralgia will favor the second and third distribution of cranial nerve number 5. So if you remember, with the 3 nerves on the face, 1, 2, and 3, it'll favor 2 and 3, whereas Sankt and Suna favor 1 and 2. In terms of epidemiology, however, Sankt and Suna are very rare. It's about 1 in every 100,000. And Sankt is also 5 times more common than Suna. So more often than not, people will have conjunctival injection as well as tearing. This typically presents very wide age range from 40 to 70 years old. It might be more common in females, but this isn't entirely clear overall. The treatment for this is lamotrigine, also called Lamictal. On this medication, around 2/3 of individuals actually do experience improvement, and the dose is 200 milligrams per day. One can also consider medications such as oxcarbazepine, topiramate, gabapentin, occipital nerve blocks, and in some situations, IV lidocaine. Um, Something that is helpful is this won't respond to indomethacin. And again, if you recall, sometimes we use indomethacin to help us diagnose things. And because it won't respond to indomethacin, this can help you kind of differentiate, are we dealing with a Sankt Suna picture or paroxysmal hemicrania? And this can help you kind of make that decision quicker and come, closer to a diagnosis. All right, so let's see, what does AI think about Sankt and Suna? Oh my goodness. Okay, so when I typed this in, I just wanted to get across that essentially this is a very painful headache that is brought on by benign activities. So as you can see in the individual on the left, you can see this person has very red eyes and crying. So this can help you remember Sankt, right, with the conjunctival injection and tearing. You can also see that this person is yawning, and so presumably this yawning is triggering this event. This other individual here, I don't know why she's holding 2 toothbrushes, but that is just what AI gave me. And you can see she's brushing her teeth. So again, benign sort of activity causing extreme pain. So again, this should help you remember conjunctival injection and tearing. So just think of this person with the extremely red eyes and tears, and think about both of them doing things that aren't that unusual. I mean, brushing your teeth with 2 toothbrushes at the same time maybe is a little unusual, but just think about the act of brushing your teeth, kind of unusual. And yawning is also very benign, right? Um, and then I thought it was interesting in the background as well that there's a bunch of llamas to help you remember lamotrigine as the treatment. Interestingly, I don't know why they all have these scary demon red eyes, but again, that is what AI gave me. I did not specify that. So kind of fun overall. Okay. So just briefly touching on the pathophysiology of what is happening here. Why do these trigeminal autonomic cephalalgias exist? What is happening? So this is basically all information that's been extrapolated off of research regarding cluster headaches. Cluster headaches, as I mentioned, are the best understood. And so most of the trigeminal autonomic cephalalgias are thought to be sort of iterations of that. Most of them are based on that kind of research. This is considered a neurovascular headache. And what is kind of thought to occur is that it's activation of the trigeminal vascular system. This also includes the trigeminal autonomic reflex as well as the cervical complex. And what happens is that this signal will travel through the trigeminal hypothalamic pathway, and this is controlled by the hypothalamus and other central pain processing regions. This will cause increased parasympathetic activity and trigeminal hypothalamic pathway with involvement. And so basically, this is involving the trigeminal, the facial nerves, and the hypothalamus. And so this is really responsible for the things that you think about, right? Like the the pupil getting really big, the white of the eye getting really red, the tearing, the runny nose. And you can actually see this reflected in the picture down on the bottom. You can see there's that eye with the big pupil. You can see the conjunctival injection. You can see the rhinorrhea or running nose. Okay. Um, so probably the best way, I mean, aside from the pictures I have generated with ChatGPT, the best way to keep these straight, the trigeminal autonomic cephalalgias, is actually to think about it in terms of duration. Okay. So it's best to kind of organize it in your brain as duration and frequency. So how often are they occurring and how long do they last, right? So let's just, the most obvious one is hemicrania continua. Again, if you're thinking about the name, it implies that it's continuous, right? So frequency per day. This is a continuous headache. And then duration, continuous. So hemicrania continua, you can think about that as the longest occurring of the trigeminal autonomic cephalalgias. Then we can think of Sancta Suna. So if you think back to the picture, remember this is very kind of benign activity that will just trigger one of these episodes, right? It's yawning, it's brushing your fingers across your face, it's brushing your teeth. So it's actually quite short, right? It's actually a very short in duration kind of symptom. However, it's occurring really frequently, right? It's 100 per day, up to 100 episodes per day. You can kind of think about it where, um, if it's really like a very severe headache, and it doesn't last as long, there's more opportunity for it to occur with more frequency during the day. For paroxysmal hemicrania, it's a little longer in duration, maybe occurs less frequently. And then cluster headache, it's occurring for up to 180 minutes or so, usually around 20 to 180 minutes, but the frequency is a little bit lower. Okay. So again, just to reiterate this, if you don't think back to the images that were generated, you can really keep this straight in your mind by remembering the frequency and duration. For Sancta Suna, it's 100 to 600 seconds, occurring 1 to 200 times per day. So think about it. If it's short, it can occur a lot. There's only 24 hours in a day, right? So if you think about paroxysmal hemicrania lasting 20 to 30 minutes at a time, and this can occur about 1 to 40 times per day. For cluster headaches, 15 to 180 minutes at a time and around 8 per day. So just remember, the longer that it's lasting, the fewer events occur during a day. And then hemicrania continua, just remember that's continuous. That's the best way to keep that straight. So thank you again for tuning in to this month's headache school. I hope you enjoyed this, and I hope you learned a little bit about the trigeminal autonomic cephalalgias. If you have any questions at all, please feel free to reach out to contact information listed on the headache school website. All right, thanks so much.